I'm Leslie Elliott Boyce, and this is The Radical Center, a recording project I began in 2022 as a way to describe and discuss the social and ideological currents that are rapidly altering our culture. In a time when political polarization seems to be the norm, I'm seeking to understand rather than react. I'm grateful to all the thoughtful men and women who share their stories and insights with me in this conversation series. If you would like to contribute to this project financially, there are links in the description. Thank you, and thank you all for listening and being part of this exploration. Today I'm speaking with Jennifer Lahl, and Jennifer, you're the founder of the Center for Bioethics and Culture, and you're a filmmaker and a researcher, and you have a new paper that you've written on fertility preservation in gender dysphoric youth. And so I am really looking forward to hearing about that and hearing what you've been working on. Thank you for joining me today.
Yeah, thank you, Leslie. This is my first podcast to talk about this fresh off the press research. So I'm excited to let you break the news.
Well, I'm excited to learn more. So what got you started on this particular avenue? What started your curiosity or your concern about this particular phenomenon?
Well, for some of your guests who've maybe heard me on your past shows, my passion has been heavily in the space of fertility medicine and especially like assisted reproductive technologies and more particularly third-party conception. So using egg and sperm donors and surrogates and all that. And, in my past, I was a pediatric critical care nurse. So I've always been interested in children, and I never intended to move into the gender debate space. It wasn't until I learned that when they were blocking puberty and when they were putting kids on cross-sex hormones and doing surgeries that I knew that their fertility was going to be compromised. And then I heard that they were being offered fertility preservation, which is the thrust of this paper. And I knew at that point that I had to, weigh in on that debate. And, I since made 3 films in the gender debate. And I reached out to several colleagues who I thought would be great co-authors. I knew I couldn't write the paper on my own. It's just, when you do a research paper, it's really nice to have a few other people to share the load and to, help with the research. And a couple of colleagues, were, definitely interested, thought it was an important paper, but they was like, my plate is too full. And I thought, this paper has to be written. And so I finally reached out to Dr. Michael Lahl, who's in my state, California, who I've met. I know him. He's an endocrinologist. And he brought along Dr. Angie Thompson, who I still have not ever really met, even though we worked for over a year on this paper. Physically, I've never met. And she's an OBGYN doctor. So I thought this is the perfect combination of people. An endocrinologist who's been very involved in what's going on with children, minors, young adults, and an OBGYN doctor to expose that we are offering fertility preservation, which is a lie. It is false hope. And this is the only time in history where fertility preservation has been offered to children that are otherwise healthy.
Okay.
You're knowingly doing medical interventions on their bodies where we know that we are going to compromise their fertility, and we are offering them a solution. So once we've destroyed your fertility, here's the solution that we will offer you so that when you grow up, if you want to have a child that's biologically yours, we have this fertility preservation. That's the why of the paper. That's the how it came to be.
So what is the actual procedure for fertility preservation? I mean, there's a lot of ethical stuff that you just raised, but I kind of wonder what's just the kind of medical background on this.
Yeah, well, think about, and you don't have to be a scientist or a physician, just think about when you're fertile, right? So fertility preservation is different if you're in your pre-fertile years, pre-puberty, or if you're a fertile person. And when you look at in human the experience that we have in fertility preservation in humans, it first started out with adult cancer patients, because we know that these are people that are already fertile. We're going to put them on chemo and radiation that might damage, harm, decrease their fertility. So we will freeze and bank their egg and sperm. Then, once we had enough evidence that it moved out of experimental and we could actually tell people that, it may work and we can get into the actual specific, it still doesn't have like 100%, 50% success rate. And there's many reasons why it still doesn't, it fails a lot of the time. Then we moved into the models of pediatric cancer patients. So here's a child, again, because of a sickness, a real disease that has to be treated or else they might die. We offer to freeze and bank their egg or sperm. But in the pediatric patient, it depends on if they've been through puberty. So if they haven't been through puberty, they don't have egg and sperm yet. They just have the gonadal tissues that's going to grow up and mature once they get into puberty. So we will offer them to freeze and bank their ovarian or testicular tissue.
Oh my gosh.
Or
Wow.
already through puberty, we can freeze and bank their egg and sperm. And we know in the data that if you're freezing ovarian tissue and testicular tissue, that even has a lower rate. So that same model would apply to the child who's gender dysphoric, who thinks they're born in the wrong body. If they haven't been through puberty yet, then they would offer to freeze and bank their tissue, ovarian or testicular boy or girl. Or if they've been through puberty, they would be offered to freeze and bank their egg or sperm.
Wow. Okay. Okay. Wow. So it's layers of potential intervention and differing success rates depending on how far back you're going. If you're going into a young child, then you're offering something that just is theoretical almost, that maybe we could end up with producing a child from your tissues. Maybe.
Yeah. And theoretical means it's experimental.
Experimental.
I mean, we're throwing spaghetti on the wall. We don't know. Work, based on adult models, based on pediatric cancer patient models, the chances are very slim. But again, it's different in that these children are going to be also on very high dose cross-sex hormones, which we know have a negative impact on their reproductive organs anyway. And we heard all the horror stories, vaginal atrophy and lack of ability to orgasm and dryness and all those other things that aren't happening in a pediatric cancer patient who's on the wrong high dose hormones. And if I could just toot our horn, yesterday they released the HHS paper that Trump directed them to report on, which is sort of our US CAS report, sort of status of medicine and science and evidence in this field. And they cited our paper twice.
Oh, wow.
Section 7. I mean, it's a 400-page, report. Many people got cited, but we were happy because the paper came out before the HHS report came out, and we knew who was involved in the HHS department. So we sent our paper quickly to them, not knowing if it would be, we would be caught up in their timeline of releasing the report. So first thing I did was, Michael and I were like, is our report mentioned?
So you were able to contribute valuable research that they used. That's fantastic.
Yeah, and the report actually says fertility preservation is unproven, which is what our paper proved. It's unproven because it's experimental, it's theoretical.
Yeah.
So
wow, that's
we
amazing.
call that a BFD in my house.
Yeah, that is a BFD. So I'm thinking about when this is being offered to kids. So these are kids who are going on puberty blockers, or kids who are being offered cross-sex hormones just across the board, these gender medical treatments. They're being told, here's the thing that you can do. This sounds like it's almost like a way to lessen the severity of the decision making. Oh, but here, you can do this, but you can still keep your fertility. So maybe it almost feels like a sales tactic or like a persuasive move to offer ways to mitigate any of the potential downsides of this treatment that they're about to undergo.
Well, it's very nefarious, whether it's a slick bait and switch or a sales maneuver. I mean, I honestly, to be fair, the CAS report, CAS actually recommends that all of these children be offered fertility preservation, which indicates to me that Dr. Cass is not aware of the science, evidence-based research that we have in the success of fertility preservation in adults, in pediatric cancer patients, et cetera. So I think in fairness, there is a lot of people that just think fertility preservation works. Oh, we just throw it out there. Oh, we preserve their fertility. Oh, okay, we'll just preserve, so it might be good intentions that are just ignorant.
Yeah.
One thing that I won't mention her by name, but a colleague of mine who's an attorney, she said this paper will be really important in legal cases because right now in legal cases it's thrown out. Oh, well, you're going to destroy their fertility. Oh, well, we have fertility preservation. Oh, okay. And she said even the attorneys who represent cases that we would want them to represent don't know that. So they don't have a rebuttal to the argument, well, we're not going to damage their fertility because we have ways of preserving it. And our lawyers will go, oh, okay. Now our lawyers, and they're not my lawyers, but you know what I mean, they can say, oh, no, there's this new paper out and that's bogus. And, I've been told that already our paper has been cited in one medical malpractice case in expert testimony to push back on this solution.
Yeah. Well, it sounds like this, I guess, technology is misnamed. Fertility preservation sounds so certain. What would you, I mean, it's like we are preserving your fertility. But if you're saying that it's not certain at all that we've preserved your fertility if we've done this, we cannot be certain that we will produce a child from any of these techniques, then what should it be named?
Well, egg and sperm freezing.
Yeah.
Because that's what we're doing. Or ovarian or testicular tissue freezing. We're just freezing your stuff. And then maybe later you can go get it. And maybe later you might, probably not. Evidence shows likely not.
Yeah.
And even really likely not if it's tissue. So.
Wow. It seems like it's a blatant case of false advertising.
Yeah. And everybody's just going along with it because I think nobody's just looked. Does it work? Oh, well, we do it with cancer patients. It's just sort of standard of care. Especially if we're doing a kind of chemo radiation that we know will I mean, there's a lot of chemo and radiation, a lot of cancers that aren't going to negatively impact your fertility, but a lot are, and I just think people didn't look and they thought, it's like if it worked over there, it's like saying, well, this antibiotic worked for that treatment. Let's just give everybody that antibiotic. Well, no, it doesn't. It doesn't work that way.
Yeah. And it also, I wonder about well, there's the informed consent question. Like, are people really being told that this thing that's being billed as fertility preservation is just is an experimental process? But also with especially prepubertal children, but even adolescents, are they? It almost seems like it's a way to assuage the fears of their parents, not them, because these kids probably don't care about having. I've talked with gender questioning kids in my coaching practice, and what you find is that adolescents, they're very happy-go-lucky with their fertility. They don't care. If you say, well, what about having kids in the future if you have one of these procedures? They say, well, I don't think I want kids anyway. And that we see that shifts for a lot of people once they're actually of marrying age and the age when people typically become parents or want to become parents.
Yeah, and because of this demographic, it's the parents that are often giving the informed consent, because minors, especially if you're dealing with somebody who's pre-puberty, they can't even understand, like you say, they're not even thinking about kids, let alone, wait, you want to freeze and bake my sperm? What sperm? Testicular tissue? What's that?
Yeah.
So. And I think it is nefarious because you're offering it, and we should, as patients or people interfacing with our medical professionals or doctors, we should think rightly that if they're offering it to me, it's something good and it's something useful. It's something that works. Versus, the doctor probably hasn't even dug around to say, does this work? I'm offering them something. Do I know it works? So I think the duty first is to the physician to know about that, or to be very candid. It doesn't really work, but you want to try it. But if you look at the very few studies that I have read, or if there's more studies out there that other people have read, please let me know. But when you're dealing with a gender dysphoric population, a lot of times they hate their body. They don't want to masturbate and
Hmm.
touch their penis to give you a sperm sample to,
Hmm.
they hate their penis. That's part of their body dysmorphia, dysphorics.
Hmm.
And there's this one study that had like a good bar graph on why most kids don't choose it. And
Hmm.
one of it, they just think they aren't going to ever want kids.
Hmm.
Two, they think if they're going to want kids, they'll just adopt them.
Hmm.
But we know kids change their mind.
Hmm.
My kids couldn't even find their shoes when it was time to go to school sometimes.
Yeah, yeah, absolutely.
Yeah, so
Wow.
quite sad.
It is quite sad. And what about the cost of these procedures? Is it borne by the individual? Is insurance picking this up? How are people paying for this and how much does it cost?
Well, we know a lot of these kids in this category, are um, Medicare patients. So
Mhm.
the taxpayers are paying for, puberty blockers and cross-sex hormones and fertility preservation care. But
Mhm.
if you look at the model of like all the Silicon Valley women who work and part of their company benefits is fertility preservation, right? You can freeze and bank your eggs if you work for, LinkedIn or Facebook or other companies.
Mhm.
And, that's a company benefit. And it's very expensive because you have to pay a storage fee every single month.
Oh, wow, really? I
Not
didn't
only
even
just
think about
the
that.
procedure of getting your stuff out of your body,
Hmm.
then there's a monthly storage fee that
Hmm.
depending on, the state you live in or the company that you're working with, that varies, but it can be in the, like $1,000 a month plus. And if
Hmm.
you're looking at a 9-year-old versus a 30-year-old at Google,
Hmm.
that 9-year-old is going to be freezing and banking their eggs or sperm
Wow, for
that
years and years.
because they're not going to want it until they're, in their 20s perhaps, or even their 30s.
Mm.
That's a huge cost. And what happens to eggs when they've been frozen for 5 years or 10 years or 15 or 20 years? Again, it's experimental. We don't really know how
Hmm.
how eggs tolerate or sperm tolerates being frozen for so long.
Is
And
there any research on that? I'm curious, like, do they break down? I know one time when we were speaking, you mentioned IVF and how you see poorer outcomes with newborns who are born via IVF or conceived via IVF. And so I'm wondering, is there any research on how these things hold up in storage?
no, because it's all attached to live birth rates, success.
Okay.
It's all attached to success. And there's no data yet on those successful babies that are born healthy.
Mhm.
And we talk about the health risks of babies born through assisted technologies in our paper because that should be part of informed consent. But
Okay.
there's no data to say this baby was born healthy from non-frozen eggs or healthy from 10-year-old frozen eggs, or healthy from 10-year-old frozen embryos, because we can freeze embryos too, not just egg and sperm. And the data in like the adult cancer patients show that the higher success rates, and again, they're not perfect, they're not great, they're not like, this is a breakthrough. The highest success rate are freezing embryos. So there's a
Mhm.
you have breast cancer, you're told, and you and Benjamin want to have a baby together. So you make embryos, you freeze them because you'll have a higher success rate if your fertility is damaged that you and Benjamin could have a baby because you froze an embryo. And
Mhm.
embryos we know freeze much better than eggs because eggs are mostly water. So the problem
Mm.
crystallize and when
Oh,
they
wow.
break. So and an embryo is more solid. So just
Mhm.
think of, an ice cube versus a pound of meat or something. And so
Mm.
we know that those kind of successes. But again, we don't have the nitty gritty for how long was this embryo frozen?
Mhm.
And
Mhm.
how long was this egg frozen? Or how long was this sperm frozen? So it really is human experimentation. And if you
Mhm.
look at how new treatments, new drugs, new procedures come to market, they work their way up through it, usually animal studies, right? We did that with organ donation and transplants. We
Mm.
were doing transplantation in animals, give a kidney from a pig to another pig, a lamb, a goat, whatever, a mice. We in reproductive medicine, we don't have those animal studies.
Mm.
We didn't start with, is it safe to freeze mice eggs or frog eggs or cow eggs, or is it safe to freeze embryos made from
Really? That
we just
surprises me. Why?
no there's no animal models that
Mm.
show it's safe, and now we'll study it in humans. And then now we know it's safe, so we can tell humans it's safe to do this. So it's one of the few areas of medicine, and I put
Mhm.
quotes around medicine.
Mhm.
It didn't start with a robust body of animal research and
Mhm.
safety trials, and then move into human clinical trials,
Mhm.
then to become used as practice in the doctor's office.
Mhm.
And that's one
That's
of the debates that we're having in this report on that the HHS department is that we don't have models of safety on blocking puberty and putting kids and people on high dose cross sex hormones. We just
Mhm.
started doing it,
Mhm.
without saying, is it safe? We don't know. We just did it.
I think it's interesting when you talked about medicine, you put it in quotes. And it does seem like some of these things, what are we doing when we're I even like some cosmetic surgery that's been around for a long time, like working on faces, improving the nose to make it prettier. I mean, there seems like there's a line when maybe someone's born with a cleft palate and you close that so that it has proper functioning, or maybe there's some really gross disfigurement, but then there's some line that and I don't know if surgeons and doctors have a sense of a really bright line or if it's kind of a gray area where things become purely cosmetic or and where they're reconstructive, where something is one or the other. And this whole realm of gender medicine, if you will call it medicine again, it's it's its own category in a way. I mean, it's kind of like the plastic surgeries that were unnecessary for function, like the woman who wants giant breast implants or something like that. Like just because it's a doctor who's trained to perform surgery who provides this, and there's a surgical procedure that one undergoes in order to achieve this, is it still medicine or are we doing something else?
I wrote a really important paper last year. I think it's important, on this very issue. What is medicine? And I've been on your show before, and we've talked about the Hippocratic Oath, and I'm such a
Mhm.
believer in that oath, which really has stood the test of time for, thousands of years now. Medicine is always should be, has always in the past been aimed toward health.
Mhm.
You go to the doctor because you're sick and you want health. You go to the doctor because something has gone wrong with your body, it's not functioning, you feel sick, whatever. And so medicine has always been oriented to health. Now, medicine can't always cure everything, but still, everything medicine does to treat you is aimed to getting you back to health. And, as we get older, the doctor can't fix things, but he can do
Mhm.
things to make things in our, I'm on medication for atrial fibrillation. I'll be on those medications for the rest of my life. Now,
Mhm.
I'm not healthy in that I have a perfect heart, but my doctor is giving me medication to try to restore my function of my heart to that of a healthy heart. Um, in this paper I wrote, I called, plastic surgery the red herring, and you see that thrown out by the gender, activists that, hate the work that I do. Well, you can go to the doctor and you can get fake boobs put on because you want big boobs. Well, that's not health. That's not health. You can call
Mhm.
it whatever you want, but that's not medicine.
Mhm.
Because medicine, yes, you can repair the cleft palate because if you don't, that child can't eat. That child won't thrive. That child won't grow. That child won't get nourishment because every time you try to feed that child, there's a big hole in the palate and the food goes into the lungs. And food is, so the plastic surgeon is doing the corrective surgery because he's aiming toward health.
Mhm.
He's not aiming toward beauty or aesthetics. So, I always say that's why we have med spas and places where people go get lip filler and Botox, and that's not medicine.
Yeah. Yeah. Well, I wonder about that line. Like at some point, there must be a point where you are improving health in a way, psychological health interacting with physical appearance is a thing. Like if someone is grossly deformed, and they're going through life with some disfigurement that causes them great anguish because of the way that people respond to them. I know you've probably seen before and afters of people who have something that gets fixed through plastic surgery, and you think, wow, to be that person and walking through the world versus being that person walking through the world would be such a difference. And it must have been really liberating and the life-giving to be able to have that procedure done. You probably imagine scenarios in your mind where that would work. But so given that most people would probably agree with that, then we get into this other realm of like BDD, like body dysmorphia or gender dysphoria, where there's more subjectivity to the psychological distress that the person is experiencing, where most people might look at the person and say, well, that's a normal person. I'm not, the world is not responding to you in a negative way because of your appearance. Your mind is responding to yourself in a negative way because of your experience with your body, your feeling about your body. And yet there are still surgeons who will sell you a procedure, even if they can't see necessarily the need for it from outside. They're going to believe your own subjective feeling about it and sell you that procedure. And I wonder what is your conception as a person who's been concerned with bioethics of how that line is drawn and how that whole like area plays out? What's going on there?
I think I'm understanding your question. So, in the case of the person that's like, let's just use the word grotesque,
Okay.
grotesque
Yeah. Like picture the Elephant Man or something,
Yeah, I was thinking Elephant Man.
Yeah, okay.
Although Elephant Man had a lot of physical problems.
Right.
He couldn't breathe, because, torsion, twisted, this, figured
Yeah.
body. Um, you know, I mean, these are people that are mentally ill. Mental illness is part of our health,
Yeah.
right? And so, to me, in my mind, the first stop is not to a surgeon, but the first stop is to a psychiatrist or a psychologist or somebody who can address your mental health struggles and treat your, again, oriented to health, get you mentally healthy so that you don't, the person, I use in this paper that I wrote, the person that wants their legs chopped off.
Yeah. Good example.
Being, a quadriplegic or a, two-limbed person. These are people that clearly have a mental distress. I don't necessarily know if they're mentally ill, but they are distressed, and it's legitimate. It's legitimate. I mean, we live in a world that our physical looks matter. I'm a woman of a certain age, and people kind of go, "Oh, you're getting," we have ageism. And do you rush off and like get things lifted and tight?
I know.
Because it's just the reality of the world. So, but
temptation.
I still would argue that that's not the role of medicine to start doing plastic surgery on person because they're uncomfortable with the physical appearance of the body. That's the role of society to be more comfortable with the fact that people look a certain way, and that's okay. I love I follow her on X, Justine Bateman.
Oh yeah.
The actress, and she wrote, I forget the name of it, but she
Face. Yeah, I think I have a copy of it somewhere here.
Yeah,
Oh yeah, I do.
You need to read it.
This one.
I mean, the problem is not the person that's grotesquely disformed. The problem is with us as a people that say you won't be accepted in this society unless you look a certain way. And then that pressure for that person to go to the surgeon who will say, yeah, sure, I'll do whatever you need to do so that, you can walk down the street and people will go, what a handsome young man he is. So, do we use medicine to correct cultural and societal problems? Because then there's no bottom to that. There really is, Leslie. We could just think all day long about the thing.
Yeah.
I don't like the look of my toes. It's like, oh my God, it's summertime coming. And I love to wear sandals. When I look down and I go, oh, look at those feet. I have such ugly feet. I'm not speaking to me. I actually have nice feet. No, I'm going to leave you all wondering because now you're all going to want to look at my feet. But, it's just that kind of, world that we live in. So that's not medicine. Even though we can, yes, admit that it's a cross to bear for that person to look in such a disfigured way. But if they're not sick and they're functioning and they're healthy, why do we want to use medicine in that way? Because then it would just never end.
So what do you think a surgeon's ethical responsibility is to the person who comes in and wants something fixed or cosmetically enhanced or whatever, that when that issue isn't affecting their physical body's health and function.
I don't think they're practicing medicine. I mean, they maybe want to call it that. I don't think insurance should provide coverage for that, which I don't think it does. I think most plastic, non-elective surgeries are out of pocket. But of course, in the gender debate, there's a lot of push to get that covered because it's not seen as a an elective procedure, seen as necessary, it's seen as treatment. So, I mean, I don't want to walk around and put them all in jail for not practicing medicine. The businesses on the medical profession, which has lost its way. I mean, one of the statistics I quote in this report that I wrote, and I can send you a link to it, is, that, medicine, doctors' morale is at an all-time low. We're predicting incredible shortages of doctors because there's a lot of people that don't want to go into medicine.
Mm.
I think it's because medicine has lost its way. And it's not what it's supposed to be, which is concerned with the health of their patients. It's now just, they're technicians. You just walk in and tell your doctor what you want them to do. I want no legs. I only want two arms. I want to be a boy and I'm a girl. We just walk in and say, and they go, okay, and they just do it. The professional societies like the American Academy of Pediatrics and Pediatric Endocrinology Society all say, yeah, this is the standard of care for how we treat these people. Instead of, no, that's not what medicine should do. So to me, the burden is on the medical profession. It's on the medical schools that are training physicians to say what are our duties and obligations as medical providers. And I think you would say it the same in your discipline and in my discipline of nursing. We have to remember what is the role of doctors, nurses, lawyers, psychiatrists, health therapists. We don't, agree to delusions of our mentally ill patients. I know plenty of people, and I saw plenty of kids in the hospital that were, truly bulimic and anorexic to the point that they had to be hospitalized because were in jeopardy of dying. We don't offer them gastric bypass surgery. We don't tell them, yes, you're disgustingly fat. We try to help them.
Yeah.
Love
Yeah.
the
Yeah. And gosh, there are so many ways it feels like the medical field has gotten lost. There's also I don't know if this takes us too far afield, maybe it's related enough to be able to get your opinions on, but the incursion of ideology into medicine in terms of the way I had a doctor on with me a few months back who talked about, he was actually a plastic surgeon who talked about how race has gotten involved in their ethical requirements to such a degree that they're forced to make acknowledgments that a lot of them don't believe in, and look at like that Black patients should have Black doctors, and that people do better with doctors that this kind of admission that all white doctors are white supremacists, so they shouldn't be working with Black patients. And these kinds of sweeping statements that just make kind of no sense according to the humanistic philosophies. And, I had my own experience with this. I don't know if I've shared this with you before, but a couple of years ago, I had an emergency oophorectomy. I had an ovary that twisted up in a fallopian tube, and I had to go in for an emergency surgery. Yeah, it was an incredibly painful and difficult experience. And when I did my follow-up checkup, I checked up with a doctor who was not the surgeon, because the surgeon was just a hospitalist. And at this appointment, this woman, this female doctor, and there was a younger woman with her as well, who was, I guess, an intern or resident or something. I'm not sure how that works with doctors, but she was obviously in training, a young doctor in training. They could not say the word woman to me in my session. I had been asked for my pronouns and on the sheet, which I ignored. But then as she talked to me, she said, she was letting me know that I had a uterine fibroid. And she says, well, about 50% of people will develop these in the course of their lives. So this isn't anything to be that concerned about. And then she goes, well, people with uteruses. And she went on to do these kinds of it was very awkward avoiding the word woman in the room when we're talking about my ovaries and we're talking about like things like menopause and my uterus, and yet we couldn't say the word woman. And I used it, but they kept on saying people with vaginas, people with ovaries, people who give birth, and things like this. And it felt it felt like I was being taught that I should think this way. It felt like they were using the encounter with me to impress me with their genderless language. Like they were jumping through hoops in order to avoid offending someone who might be offended, who isn't even in the room, because I've clearly used the word woman to refer to myself a couple of times. So it was really strange. And then it's a surreal experience to drive back out of the clinic and look up and see, you know, women's hospital on the and I'm like, are they going to turn that into them's hospital? Is it going to be they them's hospital at some point? I don't know. I don't know if we're getting too far afield by me asking you about how you see these ideologies impacting medicine, but I'm curious your thoughts.
It is actually absurd that it has so steeped in, to people who know better, who people who know the human body, who people.
Yeah.
And I was reading something just this earlier this week about, back to racism in medicine.
Hmm.
And because I read a lot in the space of OBGYN, fertility, infertility stuff. And it was, this paper that had just come out that, African American women prefer to see black physicians.
Hmm.
And I thought, I always just want to see the best physician.
Yeah.
If
Yeah.
I'm going to have a brain tumor operated on in my head, I want to know that this guy he's got this many years under his belt. He's done this surgery, a bazillion times. He's got great, report. I don't care if he's black or white or male or female. Now, I certainly am sympathetic to women who feel more comfortable with female doctors, but I don't care if my OBGYN doctor is a woman of color. I don't really I care that she's good, and I do prefer female physicians when I go, have my lady
Hmm.
bits checked. But I don't think that's, a racist thing.
Hmm.
Callie and I wrote an article, I think it was last year, maybe it was the year before, time just marches on.
Hmm.
And it was an article we wrote for Colin Wright's Substack, and it was on a paper that was promoting that trans women, so women who are on high dose testosterone and want to get pregnant and stay on their testosterone during the pregnancy because of their gender dysphoria.
Oh, that doesn't sound good at all.
And now what's the recommendation? And again, we don't have any science to recommend this. We just recommend it. The woman is told to go off your high dose testosterone for several months before becoming pregnant, so that that's sort of kind of cleared out of her system and it won't have a negative impact on the developing fetus. And we thought, well, holy hell. I mean, if your gender dysphoria is so bad you don't want to go off on your testosterone, how is growing a fetus in your uterus not going to cause you just dysphoria when the most female thing you can do is gestate a baby and be
Oh
pregnant?
my gosh.
So it was a medical paper that was arguing that this woman should stay on her high dose testosterone,
Oh my gosh.
no regard to the negative effect on the developing fetus. And so that if that's on ideology directing medical care, again in quotes,
We
it's
were
kind
told not to eat salad during pregnancy because of listeriosis. You're
you
not
can't
supposed to
drink
eat
wine,
soft
you shouldn't drink
cheese.
diet soda,
Yeah.
sushi, no raw fish,
Yeah, definitely don't eat tuna, but testosterone, fine. That's no big
and
deal.
high dose testosterone.
What has happened? It's like we entered the upside down and the clown world. Like all the ways that we used to talk about health and bodily integrity. What in the world happened? And when did it happen? What's your sense of like what sent us off in this weird direction that's so different from where we've been before?
And then you wonder why morale is so low in the
Yeah.
profession. And you wonder why we're going to have a physician's shortage, of our own doing, because there's plenty of people who really, I do believe, that want to be good, proper physicians, who
Mhm.
want to go to medical school because
Mhm.
they want to treat sick people, and not just, be part of this ideology. It's crazy.
It is crazy.
It just really grieves me, because I mean, you should be able to trust your physician. You
I
go to them when you're at your most vulnerable.
Yeah.
You're scared, you're frightened.
And I think there's many reasons why people don't trust doctors at this point. I mean, COVID was a massive blow to I guess, the credibility of the medical profession. We saw that.
Yeah.
And I don't know if they're going to recover from that. Trusting your doctor when your doctor's giving you advice that goes against common sense and previous medical findings is it's hard to come back from.
It really is.
I wonder, in your research on fertility and gender, and I was curious years ago when I first started hearing about an uptick in transgenderism, and I was searching around for people who'd written anything on this topic. What's going on? Are we experiencing something biological, something chemical? Is there something about the amount of hormones in our food or pesticides or something that's the endocrine disrupting chemicals like phthalates? Is there something that's physically causing people to be more ambiguous in their sex, in their sense of their sex self? I wondered this, and we do see like sperm counts going way down and testosterone being lower in men. So there's some evidence that maybe there is something hormonally going on with people. And I seem to remember that it would have been around maybe 2015, 2016, 17, somewhere in there. I read some research by a researcher who was themselves transgender, looking into whether progesterone given during certain parts of the pregnancy, given to a woman during certain parts of her gestation, could impact the child later on having gender dysphoria. That's pretty specific, but I wonder if that rings any bells for you.
Well, not that specific instance, but yes, there's actually quite a bit of research that shows the effect of environmental things in, sperm count. There's been quite a few studies on fish, that swim in the rivers
Mhm.
because we have, so many people, so many women, I can say women are on oral contraception, the pill.
Yeah.
And then we go to the toilet and we pee and we flush
Yeah.
our toilet and that goes into, our
The
water,
groundwater.
isn't cleared out. And so
Yeah.
there's been quite a few studies that show that fish should become asexual
Mm.
because they're swimming in, high dose. We take medication. We can take pretty toxic medication. Again, we go to the bathroom and we clear it out and we flush our toilets. Chemotherapies, if you're a chemotherapy patient, you're on, these kind of toxic medications that are basically killing your body in order to kill your cancer.
Yeah.
And, where does that end up? And, our
In
water
our water supply.
treatment centers aren't really filtrating.
Yeah.
There's all the concern about drinking plastic, water. Don't store your leftovers in the refrigerator in plastic containers, store them in Pyrex glass, because it's all that. And our human fertility is very fragile. It's not like we're rabbits and we can just conceive and, the timing of our fertility, there's this whole medical new field called restorative reproductive medicine that's trying to get to the underlying root cause of couples that are trying to conceive that are having problems, actually trying to look at what's the problem and treating it versus going directly to the big guns fertility, clinic. And, it just goes to show how orchestrated human fertility is and how
Mm.
the hormones and the regulation and between the brain and the pituitary gland and our monthly cycle and how it can easily just get off kilter. And so people struggle with just normal ovulation and normal conception and implantation. Um, and it's a new field that I'm following very closely now because their success rates, again, if we're really interested in helping people be able to conceive, the success rates are much higher than assisted reproduction. And it's not costly, it's not toxic. It's healthy because you're not doing this manipulation that you're worried about these children down the road are going to be born with different kind of, heart problems, cancers, whatever.
Mhm.
So I think it's a whole area that it's right under our noses and we're not really taking it seriously. And the problem with the reproductive restorative medical approach is it's not going to make gay couples happy,
Mm-hmm.
right? Because there's no underlying fertility issue we're trying to look at. So we want to
Mm-hmm.
move and spend our tax dollars, our healthcare dollars on, this healthy alternative. It's not going to address, or single people who just want to have a baby,
Mm-hmm. Mm-hmm.
on their own. Um, but yeah, I think there's definitely something to that. We're not like sitting here with our tinfoil hats on.
Mm-hmm.
And when you just think of the fragility of our bodies and how easy it is to get them off kilter and out of sync
Mm-hmm.
with these things that we're just doing in the environment that we don't care anything about, and the hormones in our food, and we don't know anymore, am I getting cloned meat at the safe way?
Mm-hmm.
Because it doesn't have to be marked per FDA. We don't have to mark it. This is
Yeah.
cloned cow. You just think it's hamburger.
Yeah.
But
Yeah, technology run wild. It seems like we're experimenting with so many things that we just don't know. We don't know what the results are going to be. Just like the main topic of this conversation, the fertility preservation. It's another experiment.
yeah, and so it will be interesting to see if RFK is able to really make any kind of significant changes. I mean,
Hmm.
he's going to be up against big pharma.
Hmm.
He's going to be up against, big industries that have a vested stake in the status quo. Um, and it will be interesting to see if he's able to make a dent. Does it make a dent in our health? I mean, we have a huge obesity problem, and we
Hmm.
know obesity negatively impacts fertility.
Hmm.
And obesity negatively impacts, developing children in the womb. The
Oh, I didn't know that. Hmm.
she's very obese and she's unhealthy.
Hmm.
You can't grow a healthy, it's like putting, your seeds in your garden in crappy soil.
Uh,
You've got to have this really healthy environment for
hmm.
this baby to grow healthy.
Hmm.
And so what will we see if we are able to really drop obesity rates in the US? Will we see an increase in fertility? Will we see a decrease in people that are on medication for diabetes
Hmm.
and heart
Hmm.
disease and blood pressure and stuff like that?
Hmm.
The human body is pretty damn amazing, and it's pretty tough. We can pretty much abuse our bodies. I mean, I lived through the 70s. I really abused my body hard. I'm lucky to be alive today. And as I said, it was pre-internet, so there's no evidence, there's no receipts. But it's just amazing how much abuse our bodies can take.
Yeah.
But then at some point they say, enough,
Hmm.
I'm not
Hmm.
going to work.
Yeah. Well, and it's kind of amazing with all of the reproductive assistive technology that we're also at a time when we're watching birth rates really plummet.
Mhm.
Mm.
It's kind of irony, isn't it?
It is. Yeah.
And yeah, so, and that, I know that's Elon's big concern is we don't making enough babies, but I'm not on the Elon train for how those babies get made.
Yeah. Yeah, exactly. Well, is coming back to the topic, did we get into all of the most important points about fertility preservation, so-called fertility preservation for gender dysphoric youth, or is there any point that you feel could be stressed a little bit more? And also, could you tell people where to find your research?
Yeah, well, I'll give you a link for the paper.
Okay, I'll put it down below in the
It's
description then.
not behind a paywall. It's
Okay.
open access. So I think the main idea, because even, a lot of people when they try to read this kind of lengthy paper is pretty much into the weeds because it had to be because it's an academic paper. The big idea is we've never before knowingly destroyed fertility, unhealthy bodies, and offered them a sham solution.
Mhm. Mhm.
So I think that's the takeaway, that whenever people hear fertility preservation should be offered to these kids, they should know, well, first, their fertility shouldn't be damaged because there's nothing wrong with their fertility, and what we're doing is damaging it. And they should never be offered something that most likely, overwhelmingly, won't work.
Yeah, it sounds like a massive scam and a really ethically concerning situation.
I agree.
Thank you so much for sharing this research, and I hope that these reports continue to make a difference and get in front of the right people, and I hope we're on the right path. Thank you so much, Jennifer.
Me too. Thank you. Thank you.